This is, of course, a very quick overview and very restricted description. More about it and details about it can be found in the book titled Neuroanalysis. But to sum it all up, as a connectivity imbalance for psychosis and negative symptoms schizophrenia, I would argue that this spectrum of disorders that today we call schizophrenia are actually a disorder of brain-related, in the sense that it is a neurocomplexity disorder. Neurocomplexity is the balance between overconnectivity and disconnectivity that is achieved in the brain all the time, and disturbances to this balance could explain schizophrenia symptoms. For example, schizophrenia typically starts with psychosis, which is probably a breakdown of neurocomplexity in the sense of the system becomes disconnected, and then there is probably some kind of corrective shift that the brain is attempting, moving it back to overshoot, to overconnectivity, and these oscillations between overconnectivity and disconnectivity can explain the ongoing process of the disorder of schizophrenia. So the spectrum of schizophrenia disorders can actually be summarized as neurocomplexity disorder using this outlook of brain-related disorder that we have in clinical brain profiling. As emphasized before, this was a very, very quick brief overview because trying to incorporate the whole spectrum of mental disorders in a very short clip, but more information and more detailed information can be found in the website and in the book and also in some publications. I wanted to reach this stage where we can see here, we can see on this slide, that we can actually take all sets of signs and symptoms and clinical information from the patient and translate it into a brain-related disturbance and a brain-related testable hypothesis. We can assign many symptoms and signs to the brain suffering connectivity breakdown and segregation, as you can see on the top. And other disorders, other clinical symptoms can be reconceptualized as overconnectivity, and both of them are actually a disturbance of connectivity balance. Also, hierarchical organization can be disturbed. For example, higher level organization and global organization can be disturbed, causing signs and symptoms of reduced motivation and so on, and reduced higher mental functioning. And these could be reconceptualized as disturbances of hierarchical brain organization. Hierarchical and the connectivity brain organization can be reconceptualized as neurocomplexity organization disturbances, and so on. We can continue with other symptoms. For example, as we have seen, mood and anxiety disorders can be reconceptualized as disorders of neuroresilience, disorders of the optimization and over-optimization dynamics, and that result in neuroresilience disorders. We can go on and see that the spectrum of personality disorders, as explained in the beginning of the talk, are disturbances of context processing. So we can rename them as context processing decline. This whole system, which can be called clinical brain profiling, is actually a translation of the clinical manifestations into brain-related disturbances. A translational matrix is set up in a computer program, and actually what we can do today, we can take the clinical signs and symptoms and clinical history of the patient and readily translate it using this matrix into the different disorders of brain organization, starting from neural complexity disorders through neural resilience insufficiency and context-sensitive processing. So actually, a program is set in place today for us to interview a patient, to assess a patient, and to generate this his specific brain disorganization or brain disorder specific to his clinical picture. This kind of translation is actually also a testable hypothesis for the pathology, underlying pathology of his clinical picture. So we are ready to start and see patients, and then we can prove or refute the theory of clinical brain profiling by using powerful imaging techniques, specifically imaging assessments that assess connectivity dynamics in the brain and are recently very developed. So in order to prove or refute clinical brain profiling, powerful imaging labs are needed. But the clinical brain profiling is already set for use. I think that changing the nomenclature of DSM into clinical brain profiling has advantages even before they have been proven, because they have less stigma. Instead of saying that the patient is crazy, then we say that he has a brain disturbance. And it is also useful as an orienting language, a pointer, to show us that we should start looking in the brain for the specific disturbances related to the clinical manifestations. If we continue to use the DSM, which is descriptive but non-brain related, future generations will not be able to generate the required hypotheses related to brain dynamics. And I think that clinical brain profiling has an advantage, even if we start using the name brain-related nomenclature now. They have an advantage in offering the possibility to advance psychiatry into the next generation. As a closing remark, as a closing slide, I will argue that the clinical brain profiling is extremely important if we are ever to cure any of the mental disorders that are very ineffectively treated today. Once we know the specific algorithms of brain disorganization, whether connectivity or matching complexity, we can actually use new technologies that are appearing now and that are already here to try and reorganize and reconnect or recontrol the disturbance. We have, as we can see, we have direct modes to influence brain connectivity and brain activity by deep brain stimulation or by TMS, magnetic stimulation. We can activate or deactivate groups of neurons, and if we want to connect to different regions, we can in parallel try to reactivate groups of neurons. We can also control experience-dependent plasticity. Today we have virtual reality technology, VR technology, which is developed enough in order to alter and change our perception and experience. And as psychiatrists, we can generate computer media virtual environments that will reshape the experience of our patients and thus influence experience-dependent plasticity. We have powerful medications which are synaptogenetics, and I think in the future these medications will be developed. For example, we know today that the SSRIs are synaptogenetic, generating dendrites and spines, and the combination of direct activation of brain regions and experience plasticity with these kind of medications will help us alter the brain and reorganize it. But before all that could be done, we need a specific algorithm for the different disorders, and clinical brain profiling is the provider of such algorithm. So to end this talk, I want to emphasize that real effective organization of the brain in order to cure mental disorders and to eliminate signs and symptoms, clinical brain profiling is a needed stage, and brain-oriented diagnosis for psychiatry is critical.